pulmonary embolism management. NICE updated their guidelines on the management of venous thromboembolism VTE in 2020. Some of the key changes include recommending the following: the use of direct oral anticoagulants, DOACs, as first-line treatment for most people with VTE. The use of DOACs in patients with active cancer, as opposed to low molecular weight heparin as was the previous recommendation. Outpatient treatment in low-risk pulmonary embolism, PE, patients. Routine cancer screening is no longer recommended following a VTE diagnosis. Outpatient treatment in low-risk PE patients. Deep vein thrombosis has for a long time been treated on an outpatient condition. In contrast, patients with any form of PE were typically admitted. However, in recent years, patients with a new diagnosis of PE who are deemed low risk are now increasingly managed as outpatients. NICE formally supported this approach in their latest guidance. NICE recommends using a validated risk stratification tool to determine the suitability of outpatient treatment. No guidance is given as to what tool should be used. The 2018 British Society guidelines support the use of the Pulmonary Embolism Severity Index, PESI, score. Key requirements would clearly be hemodynamic stability, lack of comorbidities and support at home. Anticoagulant therapy. The cornerstone of VTE management is anticoagulant therapy. This was historically done with warfarin, often preceded by heparin until the INR was stable. However, the development of DOACs and an evidence base supporting their efficacy has changed modern management. Choice of anticoagulant. The big change in the 2020 guidelines was the increased use of DOACs. Apixaban or rivaroxaban, both DOACs, should be offered first line following the diagnosis of a PE, instead of using low molecular weight heparin, LMWH, until the diagnosis is confirmed. NICE now advocate using a DOAC once a diagnosis is suspected, with this continued if the diagnosis is confirmed. If neither apixaban or rivaroxaban are suitable, then either LMWH followed by dabigatran or edoxaban or LMWH followed by a vitamin K antagonist, VKA, i.e. warfarin, if the patient has active cancer. Previously, LMWH was recommended. The new guidelines now recommend using a DOAC unless this is contraindicated. If renal impairment is severe, e.g. less than 15 per minute, then LMWH. Unfractionated heparin or LMWH followed by a VKA. If the patient has antiphospholipid syndrome, specifically triple positive in the guidance, then LMWH followed by a VKA should be used.